Ma'am, your mic is off. We can't hear you. Mic is off.
Sorry. Okay, thank you, Develina. Thank you. So I would like to welcome all of you again to the second series of DeCoDe engagement webinar. The topic for today's discussion would focus on the medical certification of cause of death, and then will be followed by a discussion of case studies that have come up from all of you, from your group. So I think this group doesn't need to be told about the importance of the medical certification of cause of death and why is it important to really get it right. Though that is supposed to be a very straightforward procedure, for physicians, at least for trained health personnel, the completion of the medical certificate of cause of death should be actually a very straightforward and a simple one. But definitely we have seen it is not true. There are a lot of mistakes that are occurring in the filling up of the death certificate. And as you know that once the diagnosis or the cause of death has been filled up wrongly, it actually will lead to a gross error in the mortality statistics. So it has that implication. So that's why we thought we would really like to focus on that as an important part of our continuing education for our coders, for our group. And also, since we are also going to embark on the MCCD in the near future, so we would also like to address some of the common errors and also how to improve the MCCD in our health systems. So without wasting any time, I would like to call Dr. Ayan Gupta to talk about common errors in MCCD. And then Dr. Mohan Barwa will follow with the interventions to improve the MCCOD quality. So Dr. Ayan, over to you. And also I would like to request all of you, if you have any questions, kindly put them in the Q&A box and not in the chat box. And we will try to address all your queries as much as possible. So thank you once again for joining us today. And I hope we'll have a productive evening. Yeah, thank you. Over to you, Dr. Ayan.
Thank you, ma'am. Yeah. I'll just try and share my screen. So is it visible now? Is my screen visible to everybody?
Yes. Yes, now it's visible. I can put it on slideshow.
Yeah, okay. Yeah. So good evening, everybody, and welcome to this second in our session of webinars. And so DeCoDe-VA, as you know, we're trying to improve the cause of death, and not only through verbal autopsy. Another very important component is the medical certification of cause of death, or what we physicians commonly fill as the death certificate. So death certificate accuracy, why it matters and how to achieve it. Let's see. So what is the value of cause of death data? Most importantly, why are we doing all this ICD-10 coding and such a big network has been set up? Well, if you see, this is the data which tells us about gender disparities in death. See this slide, more women are having COVID, more men have COVID-19, but women are dying more. What is the cause? So the death data tells us what is the difference. So many of the SDG 3 targets, they are related to mortality. So how do we know that we are achieving those milestones, or are we going off track? You want to see the impact of control measures on mortality trends. As you can see in this figure, this is in 1970s, seatbelt legislation was made mandatory in the European Union. And after that, you can see that deaths from road traffic accidents have been trending downwards. So these are, and finally, you can see the geographical inequities also. So that is why cause of death data is important. And as doctors, that is why we cannot be casual when we are assigning cause of death. Because ultimately, what we ascertain as the underlying cause of death, that is what is going to be coded. That is going to go into regional database, into the national database, and finally, even by international agencies, they are going to use this data to set their public health priorities. So reliable mortality surveillance is a cross-cutting imperative across diseases, across patient groups, across regions. And how do we get this death data? There are two components. First of all, we have to count all the deaths. Right now, the way we count all deaths in India is through the civil registration system. It is mandatory to register a death within 14 days. So people go and with their and then only they are issued the death certificate from the municipality or the PHC, which as the case may be. So first you have to count all the deaths. Second is identifying the cause of death. Now, although you may be counting all the deaths in the civil registration system, you're not really identifying the cause of death, because that's a lay reported cause of death. The cause of death probably you could get it from other health reports or from verbal autopsy, like we are doing in Minerva through the SRS. But then the SRS is not counting all the deaths. The other way of doing it is from the hospital discharge data or from the medical certification on the death certificate. So both these components have to be of a high standard to finally get usable mortality data. That is, if we are able to identify the cause of all the deaths which are registered in the civil registration system, then we will get usable mortality data. Now we agree that we are far away from that day coming. But nevertheless, at least we can strengthen this component. So in the absence of autopsy, after all, we are not going to do autopsy for all the deaths. So in the absence of autopsy, I think death certification by doctors is the de facto gold standard as far as cause of death data goes. Now, all doctors, all of us attending this webinar here today, and everybody always, at least sometime or the other in your career, you have certified death. So it's a very common thing which all of us are expected to do. The surprising thing is that still errors are so common. So let us see how they are common. Now, please, I will invite your attention to this case summary and its associated death certificate. So I request all of you to carefully read the case summary. 36-year-old man with chronic alcoholism for 10 years, previous history of duodenal ulcer for 3 years. Admitted with acute abdominal pain and high fever. Initial chest x-rays showed air under diaphragm. Diagnosis peritonitis, perforated peptic ulcer. Exploratory laparotomy done. Duodenal ulcer seen. Managed. 5 days later, started having fever with chills. Ultrasound revealed subphrenic abscess. Revision lab planned. Patient suddenly showed signs of septic shock, had a sudden cardiac arrest and died within 2 hours. Now, this is the certificate which has been filled in by some doctor based on this case summary. So as you can see, the immediate cause has been stated as cardiac arrest, and the time interval has been stated as 15 minutes. Next is due to as a consequence of septic shock within 2 hours. Antecedent cause is given as peritonitis due to as a consequence of peritonitis 5 days, perforated duodenal ulcer 5 days. And other significant conditions contributing to death has been written as chronic alcoholism. Fine. So based on the case history and a death certificate, which of the following statements is incorrect? This death certificate is incorrectly filled because chronic alcoholism contributed directly to perforated duodenal ulcer and should be filled in line 1E. Death certificate is incorrectly filled as cardiac arrest is mentioned as an immediate cause of death. Death certificate is incorrectly filled as the underlying cause of death is septic shock, which should actually be filled on the last line of part 1, or perforated duodenal ulcer is the underlying cause of death. So I request you to read all these statements again. And Debolina, if you can share the first poll, we can enable our attendees to answer what they feel is the correct choice.
Sir. I'll do that. So first poll for the question based on the above case history. This question, sir?
Yes.
Okay. Hello. Yes. So is it visible?
Yes, sir. It is visible.
Yes.
So let us see. Let's just wait for a little time for people to vote. Did we go ahead? No, actually, only half have voted so far.
I will wait for some. I think it needs some thinking.
It needs a little bit
Yeah.
of thinking. Yes.
Mhm. So this is fixed here, no? The box. If we can move it so that you can see the line.
Yeah,
I
if
mean
the
the
box can be moved a little bit so that the statements can be seen again.
Mhm.
It's actually.
But okay, anyway, let us.
Anyway, doesn't matter.
Yeah, no problem. We
I
can
think
expedite it.
generally, ma'am, we've got a sense of what the House feels.
Mhm. Yeah, it's a mixed response.
It's a mixed response.
Yeah.
But generally,
But can
the
the
end the polling? I think.
can everyone see the results of the poll?
Should I end the poll now?
Yeah, I think.
Yeah, I think we should end it. Yeah, let's end it and show it and share the results.
Share results. Yeah, fine. So as you can see that most of you are correct. That is 39% are correct. The answer to this is 1 and 3. And why? As we go through the presentation, I think it will become much more clearer. So we will just go back to the presentation now, and we will see why it is so. And this particular case summary has been taken straight out of the manual for physicians for cause of death certification. So those who are interested in a detailed explanation of why 1 and 3 are correct, I refer you to that document. And I think it's mandatory reading for all physicians. But I wonder how many of us have actually read it in totality. So I'm unable to shift the slide. Yeah, fine. So this is my next slide. So just we want to see some examples of how errors happen in death certification. So now you see there are certain things called major errors. Now what are these major errors? You can have multiple competing causes given in a line. Actually, in death certification, as most of you know, you're supposed to give only one specific etiological cause per line. So in the extract on the left, it has been written cerebrovascular bleed and community acquired pneumonia. Now you don't know which is the underlying cause of death. Did the person die because of community acquired pneumonia, or did he die because of cerebrovascular bleed? It's a diagnostic dilemma. So it should have been cerebrovascular bleed, whichever case he died of, that should have been in the condition directly leading to death. And let us say he died of the stroke. So cerebrovascular bleed should have been in line 1A. And community acquired pneumonia, which is a significant condition but did not directly contribute to his death, should have been in part 2. Coming on to the one on the right, clinically improbable sequence. Now you see, he has said line 1A cause of death is diabetes due to gangrene foot due to chronic bronchitis. Now this does not really make much sense. And also if you see on the right side the time interval, diabetes since last 20 years, gangrene foot since last 2 years, chronic bronchitis since last 5 years. So possibly the immediate cause would be something else, which would probably sepsis or something, which would then be due to gangrene foot, which he had for the last 2 years. And the underlying cause would have been diabetes. Agreed. But that should then diabetes should have come on the last line, that is 1D of part 1. And chronic bronchitis, which is a significant condition but did not really contribute in this chain, should have been below in part 2. Other significant contributions contributing to death. There are some minor errors also. What are the minor errors? Sequencing is proper. The what do you call it? The underlying cause of death is also okay, but no time interval has been mentioned. So one doesn't really know. The other one, illegible handwriting. Now, even with a magnifying glass, I don't think you can make out what has been written on this death certificate. So it is left to guesswork as to what statistics. And we get a lot of the narratives also we see. It is extremely, in our verbal autopsy also, we have all faced this problem, illegible handwriting. So this is a problem. So yes, Dr. Saikia wanted to say something. Ma'am, should we allow people to ask in between, or should I finish and then we can address the questions?
Let us finish the presentation and we can take up the questions later. in one go. Right? Otherwise, you can just, if you can just put your question in the Q&A box, then we can discuss it so that we don't interrupt the flow, right? Okay. Yeah. Thank you.
Then we can have a combination of errors, not one error, as happens mostly in the death certificates. We can have combination of errors. Over here, not only is there an improbable sequence. Now, ischemic heart disease may lead to renal failure, hypertension, but I think it is the other way around. Polycystic kidney probably led to renal failure and hypertension. So, as well as an improbable sequence, the certificate has also recorded 2 causes on one line, plus time intervals are not recorded. So, see, multiple causes, renal failure and hypertension. You can't write this. It has to be specific. If required, you can add a line, or if you don't have line, you can write on the last line, renal failure due to hypertension, like that. And if you see on the right side, again you cannot see the time interval over here. And also an improbable sequence. I don't know how ischemic heart disease, cataract and uremia are correlated. So this kind of combination of errors is often seen. And finally, one of the most serious ones are the unacceptable U codes. That is cardiorespiratory failure, somebody has written. Now, that cannot be an underlying cause of death. That is a mechanism of death. So what are these unacceptable U codes? We had, if those who had attended the last seminar would have remembered the concept of garbage codes. So garbage codes are these unacceptable underlying causes of death. And they are of 4 types, causes which cannot be considered underlying causes of death, like type 1 causes. So if you see type 1 cause, now in type 1 there is something called N40. N40 is the ICD code for benign prostatic hyperplasia. So BPH cannot be a cause of death. So that is a type 1 garbage code. Type 2 intermediate codes, like I50 is given. I50 is heart failure. I have to define why heart failure, how heart failure. Is it congestive heart failure? Is it some other cause? Type 3 immediate causes of death. I46. I46 is cardiac arrest. J96 respiratory failure. These cannot be given as underlying causes of death. And type 4 insufficiently specified causes like R99s, malignancy site unspecified. So these kind of codes cannot be used as underlying causes of death, especially on death certification where you have access to the medical records of a person. You cannot use this. Sometimes in the verbal autopsy you may not have got all the information, but in the death certification process, definitely if a proper case sheet is there and if the person who is certifying has seen the patient, has had some connection with the patient, then I think these kind of errors should not be made. So let us see what is the concept, just to refresh the concept of underlying cause of death once again. It is the disease or injury which initiated the train of morbid events leading directly to death. Or it can be the circumstances of the accident or violence which produced the fatal injury. And it should not be confused with the mechanism of death. So if you see this figure, heart failure is the mechanism of death. Patient died finally due to heart failure. But the heart failure could have been due to all these causes. So these were the underlying causes. And this has to be correctly identified by the physician and coded in the last line of part 1 of the medical certificate of cause of death. And how to identify the underlying cause of death, that is clearly laid out in ICD-10 volume 2. And I suggest that we should all, from time to time, we need to refresh these concepts in our mind. So it's easily available on the net. And how to identify ICD-10 volume 2 is saying that, and I think we should all go through it. We'll also host a link to this on our website so that anybody who's interested can easily access it. So to reiterate, mortality statistics are based on the underlying cause of death. So for example, you have a death due to a cerebral hemorrhage following a motor vehicle accident. Now intracerebral hemorrhage over here is the immediate cause of death. Underlying cause of death is the motor vehicle accident. The surgeon is concerned with the treatment of cerebral hemorrhage, but our public health concern is to prevent deaths as a result of motor vehicle accident. Therefore, we have to make inclusive policies which will lessen it happening. So you see how this entire thing is all interconnected. And just a quick literature review. Now, this is the medical certificate of cause of death, which is used in India. Form 4 for institutional deaths. Form 4A is what is used for non-institutional deaths. But anyway, so incomplete and inaccurate death certification, it impairs the precision of a national health information database, and they are quite common. So if you see a review of literature, in hospital-based studies, we have seen about 25% to 78% and 16% to 56% in population-based studies. I think that is unacceptably high, and it is across all countries. Worldwide, this is the thing. And many authors have gone into it, and they have classified it into major and minor errors. Major errors are mechanism of death only is listed, improperly sequenced, competing causes on one line. I had showed you the example, and an unacceptable cause. So these 4 are major errors, whereas minor errors are time interval not recorded, illegible, use of abbreviations, incorrect personal details. These are all classified under minor errors. So again and again, I want to reiterate that the quality of COD statistics is critically dependent on accurate completion of the death certificate, and more importantly, on the ability of the physicians to correctly identify the underlying cause of death. And finally, the assessment of death certification errors. How do you look for an error in a death certificate? So I invite your attention to the right side of screen. Are there any multiple causes of death recorded in any of the lines of part 1? Yes or no? Because you know that only one cause can be recorded. Is the time interval missing in any of the lines? Have abbreviations been used in any of the entries? Is it illegible anywhere? Incorrect or clinically improbable sequence of events leading to death? Sorry. Was the death due to an accident, violence, poisoning, or other external cause? In case it was an external cause, what were the details of the accident? Have they been noted? Was the death due to a neoplasm or a malignancy? If so, are the additional details there or not? Site especially. So you have to look at all these things. And finally, this is a scale which was developed by Huck et al. From Aga Khan University Hospital in Karachi. And they have, in increasing order of severity of the error, they have assigned some grades, grade 0 to grade 5. And this is what is widely used for assessing the quality of completed death certification in hospitals. So you can see grade 0 is no errors, ideal situation, whereas grade 5 is the underlying cause of death was incorrectly attributed. So as you can see, the most severe error is the underlying cause of death being incorrectly attributed or being placed in an improper sequence, which is why we are all the time stressing on how to ascertain the underlying cause of death. So with that, I have finished, and I would be handing over now to Dr. Berwa. Debolina, if you can run the second poll question. Debolina?
Yes, sir. Hello.
Run the second poll question.
Second poll means, sir.
Dr. Mohan.
Mohan. Okay. Do you feel that the training in medical certification, this one, sir?
Yes, sir.
Okay. Okay. Is it visible?
Yes, yes, it is visible.
Okay.
Yes, Dr. Pradeep, you wanted to say something?
Should I end the poll now?
Ma'am,
Yes,
should we end the poll?
yes, we can end now. Yeah.
Okay, I'm ending the poll and sharing the results.
So one can see that majority feel that it is inadequate. So Dr. Mohan will now probably tell us the strategies as to how we can improve this situation. Before we go to Dr. Mohan, ma'am, there are some queries in the Q&A, and most of them of a generic nature. If you don't mind, I can just take 1 minute and answer them.
Yes, please. Yeah, you can take up the questions. And
So
yeah,
all the questions so far are about not receiving
not
VA
received.
forms. So I will request that these questions can be left for the last part of the webinar where we have the open house. Over here, actually, we want any technical questions regarding the presentations you want to say, then you should ask. But notwithstanding that, for benefit of all attendees, I am going to state that we have finished all the VA forms of 2015 and 2016 batch, which were given to us by the government of India. Right now, we do not have any forms to share with you. Once the MOU is finalized and we have the more forms of 2017, we will be sharing with you as soon as possible. But right now we don't have, so don't worry that you have not received anything till now. We will inform you when we resume this. Thank you, ma'am.
Thank you. Okay, Dr. Mohan, please carry on. Can you unmute yourself?
Thank you, madam, for opportunity. I am starting my presentation as Dr. Ayan already discussed about the situation of the MCCD and errors what we are getting over the years and what from the literature. So I am going through the strategies what we can do and how we can further improve the quality of the cause of death data. That is very useful and very much required for national and international policy and planning and program priorities. So I am going to my presentation. So broadly, title of my presentation today is going to be strategies to improve cause of death data using MCCD, or you can call medical certification of the cause of death. Yeah, so broadly, Dr. Ayan has discussed already, but I'm going through quickly through this slide that you can see that the data starts from clinical diagnosis and that leads to therapeutic decision and subsequently death or recovery. So recovery happens, that's fine, but if death happens, then death certificate is generated. And that is useful for the families and people for the various legal and other purposes. And then goes through the expert coding and then national and international authorities, WHO and other international organizations for the program priorities. So this data is generated from basically the medical records and medical records. Two components of the medical records I would like to discuss here. One is individual patient data. Second is individual causes of the death. So individual patient data includes sex, age, date of admission, discharge, death, pregnancy, accident, and all. And individual cause of death, that is very important as a part of international form of the MCCD or medical certificate of the cause of death. So various kind of the challenges we are facing in getting all these informations and how this can be improved. So we are going to discuss that. So broadly, if we talk about the medical certification of the cause of death, the challenges can be stratified in the four categories. One is the certified level. So because the person or the physician who is filling the MCCD form may be varied by the experience and specialty, and that may affect his observation or his the decision about the cause of death. Second, problems related to the certificate. This is if we talk about our country, the medical certification of cause of death as per WHO or international form, but in some countries it is not per form. So that problem is one. Second problem, we are not filling a form properly. Instructions are not read or coding process is not sufficient enough. So that may cause various problem in the processing of the data further. And these last two box you will see about the subject and attribute. This is basically the quality of the medical records or the clinical data which is coming. For example, information availability about age, sex, coexisting morbidity, Similarly, cause of death in terms of the nature of condition evidence. When these informations are not properly available, then it becomes difficult for uh, identifying the cause of death or the underlying cause of death, and subsequently it may be problematic. So broadly, if we go by that, how we could address this problem, so we would say that the continued training on the medical records, MCCD, medical certification of cause of death, ICD-10 coding is the most vital strategy to achieve adequate quality of medical records and to arrive at correct underlying cause of death. But broadly, I will classify the strategies in the three components that including national and international, national and regional level strategies, and medical education and training strategies, and hospital strategies. So national and international level strategies, national and regional strategies, we can classify in the three parts. One is establishing a national stakeholder group that should have a representative from the data users like civil registration, statistics and planning, and Ministry of Health, and various medical professional organizations that involved in the implementation of the hospital improvement, and those are representing the medical professionals. So this committee may guide about the sensitization of the utility or use of the cause of death data, or medical certification of cause of death, and they may further provide opportunity for the their sensitization may further provide opportunity that how we can take forward at the broader level for a physician level or the provincial level or likewise. Second is about the introduction of the medical certificate of cause of death, the international form that is already in place in our country, but some countries are not in place. So this is also important. And third part at the national level, that is the improvement or introduction of the clinical coding of the medical certificate. So basically medical coding strategy, clinical coding strategies to be developed, and there has to be in place. So this process is known as, we can call it, manual process of the translating diagnosis from text or from forms to alphanumeric codes for the storage, retrieval and analysis of data, and that analyzed data to be used for the policy and planning. And another, the one innovation is now is automated coding. Iris is an automatic platform which is available for the multiple causes of the death, and it is used in some countries successfully, but in our country it is not implemented till now. But this is one of the strategies that can help for further improvement. Second part of the strategies I would discuss, that is medical education and training opportunities or training strategies. That includes, one part is developing training curriculum and the materials. So that may emphasize on knowledge and importance of the medical certification for the public health policy and practice. Second, required skills for the completing and accurate medical certificate, and the attitude of the medical professionals, because largely it is understood that the medical professionals don't consider as a core part of their job. So it is important, and they need to be sensitized. Second, when we have a training curriculum and materials, we need to implement. So for that, a targeted training program will be needed. So physicians must be formally trained that how to use this form and understand how correctly can be certified the sequence of event that leading to death. And second part of this training program, that may be training of the trainers, given the scale of the training required. For example, the countries like India, where the number of the physicians would be huge, and secondly, regular refresher training will be required. So training of the trainers model can be used as a feasible and sustainable model. And this is just an indicative slide that the different type of the stakeholders involved in the cause of death, the data, or especially MCCD, and the training level may be different for them. So for example, for the trainers, all perspectives of the training components should be covered. But for the Ministry of Health officials, senior physicians, junior physicians, educators, and students, there would be the different level of the training program may be customized. Third part is the hospital level strategies. So this include establishing clinical audit committees. So to make it this process of the MCCD as a sustainably improvement in the quality of data, we need such committee. So already hospitals used to have various committees. So there has to be a dedicated clinical audit committee that help in implementing the training programs and improving the medical certification of the cause of death. And this committee should keep watch about the adequate training or refresher training for the certifications, including coding, regular audit, and reporting and dissemination of the results of the audit process. So it is useful for the hospitals as well as other stakeholders. And this learning can be utilized for further improvement of the cause of death data. Second strategy that would be hospital level is the quality of the certification. So assessment of medical certificate for correctness and completeness should be done regularly, and reviewing of the medical and clinical records, whether the underlying cause of death has been recorded. So this measurement and monitoring process should be in place at the hospital level. And third is medical record systems. Basically, this is about storage and retrieval of the medical record data. That is very important for the medical certification process, because physicians may sometimes need historical data that is present in the records, and they may like to revisit for the finalizing their diagnosis about their cause of death. So that is important. Second, the value of this record systems in the situation analysis, and we need to provide this dedicated space for the physical storage where it can be retrieved whenever needed, and there has to be a policy for retention as per regulatory bodies of the in-country, and numbering system for the records, task defining of the various persons which are working in the medical record systems, and whenever plan to change over to electronic system, so there has to be a plan. So these are the techniques to improve the medical record system. So these are three kind of the strategies that can be used to improve medical certification of the cause of death. So now broadly, these are the different level of strategies, but ultimately everything goes to the training strategy, because the training is the most important component which affect the main stakeholder, that is the physician, which used to fill the MCCD form. So this is, I am presenting this from the case study. I won't go into the detail, but quickly I will go through it so that you can have a understanding that what could be proposed and what could be done and what is being done in the different countries. So this is part of the Bloomberg Philanthropies Data for Health initiative at the University of Melbourne. So they propose three types of the training strategies. So one is the training of the trainers. This has been used in the Philippines, Myanmar, and Sri Lanka. So what they done, they have trained the key trainers in the country, and then they further trained the government hospitals or the various, and the variable approach has been used in the different countries based on their health systems. Second, direct training strategy, it has been used in the Papua New Guinea, because this is a small country. So when the program was developed, the trainers directly trained all the doctors. They have identified the main hospitals of the country. They has been designated as the training hospitals, and they have provided training to all the physicians. And the third training strategy is the online system and basic training strategy. It has been used in the Peru. So they combined use of the online system for the notification and certification and face-to-face training for completion, for accurate completion of the medical certification of cause of death. So this is about the various training strategies. So I won't go into the detail, but just briefly give a view of it. In the Philippines, they have used TOT method. So they have used 2 days training for the hospital level, large hospital level physicians, and they have provided training for the other staffs. And they have also piloted regular assessment method for the death certificate in some hospitals to ensure the quality assurance. Basically, large hospitals has been targeted. And direct training strategy, as I have said, it has been used in Papua New Guinea, given the small country. So they developed first a comprehensive mortality surveillance system. The training was given for that. Then they have given training for the medical certification. Refresher training has been included, and monitoring for the post-training period. And in addition to that, what they did regular advocacy meeting with senior physicians at each site and Department of Health as a part of this strategy. And later on, this entire program has been included in the medical curriculum of the medical school. And this was the Peru's model. So what they did, they used online death notification and certification system. This is known as SENA-DEV, and it was used in the health facilities and mortuaries. And Ministry of Health developed a training program for physicians to accurately filling the MCCD form. And they use a core team of the trained physicians, other professionals trained, all the physicians and statisticians, that how to use this SENA-DEV, and this another training program was used. So broadly, this for what the training program they have used 1 hour for the online and 1 hour for the MCCD. And ideally it required half to full day, but most of the hospitals and physician organizations agreed that 1.5 day would not be feasible for them. So they compromised on the training duration. So this is also important challenge. So while developing strategies for the training program, it has to be kept in the mind. So based on this, we thought of the blended approach for the India. So for now, what has been there, and see, the Government of India has developed e-more application for recording the mortality. So this is the online death notification and certification system already in place, but it is used in the selected hospital. It is not implemented throughout the country. So this is one opportunity. Second, online training module for the accurately and completing accurate and complete filling of the medical certificate of cause of death. So for now, there is a paid course on the MCCD is available by some university, but now AIMS and Minerva Network has proposed to develop online training module that would be freely available for all physicians throughout the country and elsewhere. And in addition to that, mandatory training in the accurately completing MCCD at various professional stages may be useful. And in fact, it is the need of hour. And the inclusion of the short course as proposed by AIMS Minerva Network can be included in the UG and PG medical curriculum. And opportunistic training in terms of the webinars, conferences, CMEs, it can be done in collaboration with various professional organizations, and they can be helpful for this purpose. So this approach we have proposed about the India, and we are taking to lead in developing online training module for MCCD. But one problem still remains about the quality of the medical records. So there has to be some strategy, or there has to be some concrete program. So now I'm sharing some available resources for a medical certification of cause of death. So one is a physician training manual, which is available in the given link. So you can download and you can read. It is freely available. This entire process has been discussed in this manual. This is for the Government of Indian setting or the physicians of the India. Second is about the coding. So for the coding, this online tool is available by ICD-10 that can be used for the train, or we are also likely to propose some component of the ICD-10 as a part of our module. Second, if you are interested about the knowing information about MCCD, then you can visit to the Census India website. All the reports and other informations and other notifications are available here. And one online course, as I have shared, that is by St. John's Research Institute. It is available, but it is the paid course. So we are not promoting it, but informing you just for the information. And we have proposed the online course for the MCCD that likely to come in the few months, next 2 or 3 months. So this is all about all about the strategies. And if you are interested in ICD-10 online training module, you can visit to this URL given here, and you can go to ICD-10 online training. This is broadly required for those who are interested or who are involved in the coding of the cause of death. So thank you so much for patient listening.
Thank you, Mohan. That was a very interesting presentation, and also highlighting the practical aspects that we can do from our side to improve the cause of death, MCCD. So let's just open this floor for questions if anybody has anything. Yes, we will be sharing the presentations with you. So that is both the presentations we'll share with you by email, and we can take up a few questions before we go to the next session. We have another interesting, the second part of this webinar will be a discussion of actual case studies. So we'll just take 5 minutes for discussion if there's anyone who wants to ask questions on these two presentations. If not, then we can move on straight to the next to the next part. I can't see any question. So probably let us move to the next part of this webinar. I'll hand over the floor to Dr. Rakesh Kumar. He will be the one to moderate the next session. So Rakesh, over to you.
Thank you, ma'am. Good evening, all. So now in this session, we'll be discussing, and that is all the kind of coding challenges that we have while we code the viral autopsy. All of us come across a lot of forms, viral autopsy forms, where it is kind of challenging to code. There are a lot of interesting narratives. The history is very narrative. We are not very sure that which way we should code it. And so that's why we have kind of brought out few interesting narratives, and we have got 3 experienced coders with us. So without wasting my time, I would request Dr. Sithansu, and how we'll do it is that we have 2 case studies each speaker. So what we'll do is first we will go through one each speaker, one each panelist, and then we'll come to one another round to the panelists. So first, I will request Dr. Sithansu to share his case study.
Thank you, Dr. Rakesh, and thank you, everyone. Can you hear me?
Yeah, we can hear you, sir.
Yeah, so I'll just share my screen. Is it visible? The full screen is full screen?
Yes. Yeah, sir, it is visible.
Yes. Yeah. Thank you so much for this opportunity where we are benefited by the last coder engagement strategy that AIMS technical support unit did. So we're very thankful for the group and a lovely experience of getting involved ourselves for last 1 or 1.5 years. So our job is to now discuss some of the challenging issues that we have faced in our day-to-day practice of coding forms. So I usually do for the form of ODIA, and because it is in this form I coded, and we will see the narrative in English in the subsequent slide. So this is a case of a 54-year-old male. As reported by the respondent, the deceased was healthy and was able to do all his activities of daily living. There was history of alcohol and smokeless tobacco intake. On the day of death, he went for work and returned home drunk at 2 p.m. in the afternoon. He slept off without eating. After an hour, he got up and started vomiting. There was presence of blood in the vomiters. He was referred to a higher center by the nearby health facility. And after 1 hour of treatment in the higher center, the patient died. There were no reports available. It was mentioned in the narrative, which is a good thing. No history of fever, diarrhea, chest pain, or respiratory illness reported. Now, if we can have the audience poll, what do you think probably will be the cause of this underlying cause of death for this case? Then we'll go for further discussion on this. So if Devolina can please put the audience poll for me.
Yeah, sure, I'll do that. So just confirm me. I'm reading out the query. This one. What do you think as the cause of death in this case? This one, sir?
Yes.
Okay.
we'll give the participants about 1 minute, then we'll close the poll.
Okay, sure, sir. So should I end the poll now?
Yes, please.
Okay. I'm sharing the results.
Yes, please.
Yeah. Yes.
So the result shows there is a little bit of confusion. 40% have told it to be alcoholic liver disease, around 30% toxic effect of alcohol, and 24% hematemesis. Right, we can close that. Right. So now let's go and see what should be the cause. Now in this case, the coder 1 and 2 also what we got is also the same thing, toxic effect of alcohol. But before we go to the toxic effect of alcohol, let's see what is toxic effect of alcohol or alcohol poisoning. What it says is the consequence of drinking large amounts of alcohol in a short period of time. Drinking too much too quickly can affect your breathing, heart rate, body temperature, and gag reflex, and potentially lead to coma and death. So these points were not there in the narrative. So what it says, secondly, the T section, as discussed earlier, it belongs to the section where we say it as a garbage code. So we should try to refrain ourselves from the coding of this type of thing as P or S. Now then, in that case, what should be our the cause of underlying cause of death in this case? Can it be something else? So let's revisit the history. There is history of alcohol intake. We do not know whether it is chronic use, but as we understand from our background knowledge that anyone 50-year-old male, when they give history of alcohol intake, preferably, mostly it is a chronic use. There is blood in vomitus, so which is hematemesis, and it is actually defined as the regurgitation of stomach contents mixed with blood and regurgitations of blood only. Swelling of blood from a mouth injury or a nosebleed, can be upper GI bleed, which is a possible cause, or it can be alcoholic liver disease, which is more likely. So why it is upper GI bleed can be ruled out is there was no history of abdominal pain and other things earlier. So that's what is ruling out the upper GI bleed as a cause of death. But here there is the history. It says that there is alcohol intake and hematemesis. So both the things goes for the underlying cause of death as alcoholic liver disease, and it should be coded as case 70. So this is the end of the first case study. If there were some doubts or some discussion points from the participants, we can discuss this. Otherwise, we'll hand over it to the next panelist. Over to you, Dr. Rakesh.
We'll just wait if there is any question, Dr. Sitanshu. If
Sure.
Just wait for a few seconds, and if there's no question, I just wanted to emphasize one more thing here.
Yeah, please.
And that is, I mean, we have been emphasizing it again and again, and that is an important part. That I mean, ICT bars actually you should not code SNT code, so that is just out of question. So that is, I mean, that should be. I can't see any question in QA. So now I'll request Dr. Farhad Jama to, sir, please, if you can share your case study.
Thank you.
Okay,
Is
sir.
it visible?
Yeah, please go ahead, sir.
Okay, thank you, sir. Good evening to all the participants. I think the slide show. Yeah. So I'm Dr. Zaman. So I will be also sharing some of my experience, real life experience that I have experienced with the coding challenges. So this was narrative one, as our moderator has already explained that first we'll share one narrative, and if time permits, then we can go for the next. So I have just given a summary of that Hindi narrative. It's a 52 years old male, and as per the respondent was a known patient of diabetes undergoing treatment in a hospital in Chandigarh. And the narrative has mentioned that there was a kidney damage due to diabetes. And also the narrative has mentioned that they need to visit hospital regularly. They have not given any details why they are visiting twice a week or something like that, but they have given that they need to visit the hospital regularly, and ultimately died at home after 4 to 5 days of returning from hospital. So this is in a nutshell. It's not a line by line translation, but it's the summary of the narrative which we'll discuss today. So may I have the audience poll now? Please look at the summary of the narrative. Known patient of diabetes undergoing treatment, kidney damage due to diabetes. That has been mentioned by the, the one who has narrated. So may I have the audience poll now?
Yeah, sure, sir. So this one. Dr. Zaman,
Yes.
is this, yeah.
Yes, this one.
Yeah, we can see. So based on the narrative and other given details, what code can be assigned as the underlying cause of death? So you can see the multiple option. Unspecified diabetes mellitus E14, B unspecified kidney failure or renal failure N19, or C unspecified diabetes mellitus with renal complication E14.2, or D ill-defined and unknown cause of mortality R99.
Should I end the poll now, sir?
Yeah, I think
Yes, yeah, okay, you can. At least we got an idea of it.
So this is the result, sir.
So I can see that जानबूझ के मैंने C option दिया, that unspecified diabetes mellitus with renal complication. It seems to be the choice of most of our person, 82%. But let us, because the underlying cause of death or the ICD code that we give here, we are not new to the system. We know that we are not allowed to give decimal. Otherwise, if we see it from the death certification point of view, it's okay. Let us go one by one. So based on the, sorry. So it was a known case of diabetes undergoing treatment, and it was a renal failure and history of regular visit to the hospital, which might be due to dialysis, but we do not know because it is not mentioned in the narrative. And now two conditions are very clear. One is diabetes, second is renal failure or kidney failure. The dilemma is whether to code N19 unspecified renal failure or E14 unspecified diabetes mellitus. We can't code, unfortunately, E14.2, which would have been the most appropriate without any controversy in this case, but our system in verbal autopsy in Minerva also, we cannot code decimal. We have to code, alphanumeric, not any decimal. Otherwise, E14.2, as most of you, more than 80% of you have said that this is the most correct underlying cause of death. I do agree, but can we code this in our system? It does not allow. So now the dilemma remains how to solve the problem. Now let us see what is the underlying cause of death. As per WHO, the disease or injury which initiated the train of events leading directly to death. Then the diabetes E14 seems the answer, because renal complication has arisen because it's a diabetic nephropathy because of the underlying diabetes. But is diabetes a risk factor or itself a cause of death? So diabetes is considered a risk factor, and according to the principle of verbal autopsy, a risk factor should not be assigned as underlying cause of death unless no other cause of death is found. So you can see that there are so many risk factors which itself may be a cause of death. And one of the foremost among them is diabetes. Other, we have got hypertension. Then there are some other risk factors like alcoholism, smoking, obesity. Those are all the risk factors. But among those risk factors, diabetes is one such risk factor which itself may be a cause of death. So let us see. Or is it N19, unspecified renal failure, the appropriate code? But let us remember that many of us consider N19 as a garbage code. As Dr. Ayan in his first presentation has already shown, it's a type 2 type of garbage code. N17, acute renal failure, N18, chronic, and N19, unspecified renal failure is a garbage code. So what are those unusable codes or garbage code? Dr. Ayan has already explained. But to be clear, because this type of cases, most of the coders, most of us often encounter. I mean, whether to give diabetes or the complications of diabetes, which has ultimately lead to the death. Whether that complication is the immediate cause and diabetes is the underlying cause, or whether the complication itself is the underlying cause of death. So for me, it has been always a challenge. I have been doing verbal autopsy since last 13 years, since 2007. But this point has always been a challenge. So what is the garbage code or unusable code? Any code that cannot be or should not be an underlying cause of death, such as septicemia, senility, or headache, a cause that belongs in some other part, the morbid sequence of events leading to death, or the cause of death that is insufficiently specified. So ultimately, we decide to code E14 as the underlying cause of death, as use of N19 in informing the public health policy as the related underlying cause of death is too vague or simply not useful. Here we have to see that the verbal autopsy which we are doing through this platform of Minerva, it is, Dr. Ayan has already discussed, it is for the public health. At least from the E14, we come to know that the person was suffering diabetes, and diabetes was, from diabetes started the chain of events which ultimately led to the death of the patient. But if we code N19 or renal failure, unspecified renal failure, then we do not know what exactly might have caused that renal failure. It is something like heart failure. It is a mechanism of death. So it might be due to hypertensive nephropathy or diabetic nephropathy or some condition of the kidney itself. So here, let us end the dilemma. It is not N19, it is E14. But frankly speaking, I myself have been making the mistake of giving preference of N19 over E14, because I was thinking E14 diabetes as a risk factor and not as the cause of death. Sometimes only diabetes is mentioned. There it is okay. You don't have anything else, only diabetes is mentioned, we give E14. But when renal failure along with diabetes is mentioned, there is always a tendency to give renal failure N19 or N17, 18, 19, whatever it may be, whatever specified is given, rather than E14. That was my first narrative and the discussion, and I think many of us, many of the coders might have faced the same dilemma. Thank you.
Thank you, sir. Now I will.
So you are on mute. Please unmute, Dr. Rakesh.
Yeah. Okay, ma'am. So the one question was, why can't we quote 14.2 when DM and renal failure both not specified? We are instructed to code according to given details, not assumptions. That was one question, sir. Why can't we code it as 14.2? And I think Dr. Farhad has already mentioned that very clearly, that in our viral autopsy coding, we are going with 3-character codes, not the 4-character codes. So that's why we go with E14, not with the E14.2. If there is any other question on this, we'll wait for sir a minute, and then if there is any other additional queries are there. So yeah, so this E14 and N19 dilemma is answered. So what again? One thing that I just want to clarify here. This is a big dilemma, actually. This is actually a big dilemma between N9. So if you just look at the ICD-10 coding system, and there we have something called as, and we have that in kind of incorporated in our training modules also, something called as dagger and asterisk system ICD-10 has. And that is applicable to kind of 4-character code. So when there is a dagger and asterisk, so dagger is taken as underlying cause of death. So dagger in this case is diabetes and renal failure is asterisk. So in 4-character codes, there is a very clarity that it has to be 14.2. There's no confusion. Why there was confusion? If you just look at the earlier million death study, they take a very clear stand, like, and that in cases like this, they will code it as N19 and not E14. That they had taken, and maybe because of having that parity, having that kind of comparison and all that. So we want to compare earlier years data. So we went ahead and included that as N19 in our coding system. But I totally agree that E14 should be mentioned, and going ahead, we should stick to that. So that was one. The other question is it necessary that other 2 coders also think similarly and assign same cause of death? Obviously not. I mean, that is the issue with the viral autopsy, is that 2 coders might think very differently. That's why we have this system of 3 coders, where if 2 coders kind of agree, then we assign that. So obviously we agree that in viral autopsy, it is not very precise thing. So that was another question. And one question was there for Dr. Sitansu from earlier presentation, is hematemesis is the immediate cause. Yeah, so hematemesis may be the immediate cause, but obviously and it's very clear in underlying cause that event that has kind of started the chain of events. So obviously hematemesis will never be the cause of it. Now I will request Dr. Biswalata to share her case study.
Sir, just 10 seconds.
Yes, sir.
When sir. I was searching for the interesting cases and got these, and there I had coded N19 only, and it was matched. I mean, the other coder or the adjudicator might have coded. So you are correct. The other system, I mean the million death study system, there it was stressed not to code E14 rather than code N19. But when I studied the whole system, I have gone through the literature, then I could find out why we should not code N19. It should be E14 only.
Yes, sir. In fact, when our training material says that we should code N19 and not E14. And we consciously kept that because we wanted comparability with the earlier causes of death. Going ahead, we should start coding it as E14 and not N19. With that. Thank you, sir. Dr. Viswata, please.
Okay, thank you, Dr. Rakesh. Am I audible?
Yes, ma'am. You are very much audible.
Okay, I'll just share my slides. Good evening, everyone. I'm sharing from Imphal. I'm presenting a narrative of a 31-year-old male, and it goes like this. According to the respondent, the deceased had a biopsy done at RIMS Hospital, Imphal, 6 months before his death, since he had a swelling on the neck. It was found to be a tumor. He was then referred to undergo treatment at Tata Memorial Hospital, Mumbai. He underwent chemotherapy there. However, he could not be treated and came back home. He died 12 days after reaching home. In the additional data, in the past history, it was revealed that he was HIV/AIDS positive. So before we go ahead, can we have the audience poll for this narrative?
Sure, ma'am. I'll do that. Is it visible, ma'am?
Yes, thank
Okay,
you.
okay.
So it goes like this. What is the underlying cause of death for this 31-year-old male? First option is D09, carcinoma in situ of other and unspecified sites. Second is C39, malignant neoplasm of other and ill-defined sites in the respiratory system and intrathoracic organs. Third option is B21, human immunodeficiency virus resulting in malignant neoplasm. And the last one is R22, localized swelling, mass, and lump of skin and subcutaneous tissue. Should we end the poll?
Sure, ma'am. I'm sharing the results.
Okay, so maximum have given B21, 61%, 18% for the first and second option, and 3% for the last. Okay, thank you all. Let's go ahead and see. So, can't go down. Okay, so the key points in this narrative is that because the neck swelling was diagnosed a tumor for which he was referred to Tata Memorial Hospital, that means the tumor is a malignancy, but we do not know whether that is a primary or a secondary. And fourth point, chemotherapy was given. But despite the chemotherapy, the patient died within 12 days after returning back, which is indicating signs of very aggressive malignancy. And another additional data is he is HIV positive also. And one of the aggressive malignancy in HIV positive cases is it could be this B cell variant of non-Hodgkin's lymphoma, which usually presents as neck swelling also. So let's see what were the codes. The first coder had assigned D09, carcinoma in situ, which is unreasonable because this cannot lead directly to death. That has the lesion has to progress to malignancy for death to occur. And another thing we should note is Manipur is one of the very high prevalence states of HIV/AIDS. And if we had assigned a C code, and if the coder had missed this additional information about HIV positive status, then we would be underestimating the HIV-related deaths in the state. So the final code, and as the educator had also assigned, is B21, that is human immunodeficiency virus, resulting in malignant neoplasm. If there are any queries, we can discuss. I hand over to Dr. Rakesh.
We'll just wait, ma'am, for if there are a few queries where. So,
Somebody raised their hand.
I can't see. Is there something there?
Dr. Islam raised their hand.
So, what is
I
the?
request, if there are any queries, to type in the.
Yeah. So there is one question as the. Sorry, I think this is not related to these queries. So, Dr. Mir will take that maybe towards the end. When cancer, other causes take backseat was told. Okay. So, yeah. So that is there. But if you just look at the cause of this thing, I mean, there's certain exception in ICD coding system. And there is something called as assumed direct consequences. If you just look at the rules, ICD coding has various rules, rule 1, rule 2, rules, all those kind of things are there. So, so there's something, rule 3 says assumed direct consequence. So in this, what happens is that in case of HIV, if there is a, say, Kaposi sarcoma or Burkitt's lymphoma or any other malignant neoplasm of lymphoid or hematopoietic tissue, and they have said it falls between, say, C81 to C96, C46, and other causes. So there, it is clearly mentioned that you should, sorry, you should code HIV as the cause of death wherever there is a kind of, and the same rule applies for, in fact, diabetes and renal failure as well, diabetic nephropathy. So there are certain exceptions to the rule, but I think we should be following that rule. And in any case of HIV where a lymphoma is there, so it is assumed that lymphoma is as a direct consequence of that is one thing. That was one query. I'll just address a few of them. So it says not, Meher Rupani says, Dr. Meher says, that not related to these narratives, but in many narratives, they mention the patient having only hypertension. Essential hypertension is considered as a garbage code. In such cases, what should be coded as underlying cause of death? So again, I mean, this garbage codes is, I think, a very interesting thing. But if you don't have any other information, I think we should go with whatever information is there. So if only hypertension is mentioned, no other information is there, we should go with essential hypertension. So there's no issue in that because there's no other information. And then second says, Mary narrative mentioned Hridayaghat as the cause of death. Respondent's cause of death, stroke, is mentioned. Even in such cases, history section 2, stroke is selected, but the narrative says towards heart attack. Is Hridayaghat to be considered as stroke or as heart attack? I think Hridayaghat has to be heart attack, not as a stroke, but it depends. I mean, place to place, I don't know how what does this word means, but if I look at the literal translation, it has to be heart attack.
With your permission, sir, just to add, the same problem is with Assamese and Bengali, because when they say stroke, some mean heart attack also. MI also they tell it as stroke. Sometimes some people tell heart ka stroke and brain ka stroke, but stroke they take it for both stroke and heart attack. So I think you are correct. If they are telling Hridayaghat, then we should take it as MI only and not as stroke.
Yes, the other issue is, again, it will depend on the local cultural this thing and what we are trying to also incorporate, which is not there till now. So what we are trying to incorporate in our platform is if we can put the state from where this data has come. So at least we know that in that state how this term is being used. That local cultural context is very important. How a word is meant in a particular cultural setting. So that would be important. The third query was in newborn babies. Based on the narrative, it was really very difficult to select between pneumonia, birth asphyxia, respiratory disease of the newborn, bacterial sepsis, and other congenital malformations. For example, newborn babies, many times we mentioned the baby head. Yeah, I think obviously that is there actually. That is important finding, and it is difficult actually. So I think based on your clinical understanding, what you feel is correct, you go ahead with that. Because ultimately, when we club them into this thing, they are likely to be clubbed together. So I don't think there's a big issue over there. So, Ayan, do we have time for another this thing, or
you can do an audience poll. I'm the only audience who is unmuted. So
I think we can do two more. So we have only two more. I think.
or I think suggest you others don't give a detailed reply. Just give the question and the answer. That's all.
Yeah, I think that will be okay.
A detailed explanation may not be given.
Yeah, okay. Dr. Sitansu, you can.
Sir, just 1 minute if I can come in over here.
Yeah.
So in the earlier one, somebody said that essential hypertension is considered as garbage code. Actually, just wanted to clarify that essential hypertension is I-10, and it is not listed in list of garbage codes actually.
Okay, I mean, obviously, garbage
It
codes
should
are
not
also
be.
not.
If something else is there, it should not be used because it is a risk factor, as Dr. Farhad had that discussion.
All
It
that
is not.
I have to.
That's all.
All that I have to say is garbage codes are not that garbage. They also throw out some information. So we should not
definitely. We cannot rule them out. They are post hoc.
Yeah, that's it. We should not be too dismissive of them. That's all that. Dr. Sudhanshu, if you can next.
So I'll just go through. We'll not have the audience poll. I'll just go through the. So the second narrative is
No. Have a audience poll, but don't give a detail. Just give the correct answer. That's all.
All right. As for the respondent, it is about the 52-year-old male, occasionally complains of pain, abdomen, and severe diarrhea, gets medicine from the nearest health facility and feels better. 4 to 5 days prior to death, he complained of reeling of head, high-grade fever, and also had watery diarrhea few days back. He continued to do his daily activities, then suddenly fell down, hit his head, died on spot immediately. There was no history of raised blood pressure mentioned in the narrative. So what do you think the cause? So can we have the audience poll? We can give 30 seconds and we'll try to see what cause.
Sure, sir.
Current guidelines. Okay, the speaker.
I think we can close the poll now. Can we see the results, please? Yeah, thank you. So around 43% were telling it is unspecified fall, and the other things are distributed. So let's look at the answer for this. So the coders have got different coding for this particular narrative. So STR. So let's revisit the history and see what is it. Actually, there was fever, history of fever and diarrhea. There is history of fall, head injury, and sudden death. Now, why he fell? That is the question that we need to find out the answer for. Is it because of diarrhea, which led to hypovolemia and severe volume depletion? Nothing is mentioned in the history. We do not know about this. Is it because of incoordination due to fever? Because he was doing his daily activities, probably this is also ruled out. Can it be accidental fall? Probably that is what we can think about it, because the other codes like S01 and T99, as it was told, signifying the body injury. Many people have usually go for the injuries of the head, which is which is not the code to be used, because signifying the body site of injury are not to be used for underlying cause of injuries. Hence, we went for the W19 unspecified fall category. So this is how this was coded. This was different people have got different coding for underlying cause for this, but unspecified fall. I'll take one more minute to share my experience as a coder. When I started, the best thing that I found useful is read the narrative twice. If you read it twice, then the story becomes better, and we should spend some time to understand the story. Focus on the key symptoms, as it was already told. And sometimes the arranging symptoms in chronological sequence always helps. Avoid, all these things have been told again and again, risk factors, non-specific symptoms as underlying cause of death. Certain specific codes, the garbage code discussion we already had. In case of injuries, site and nature of injury should not be coded as underlying cause. Rely on your clinical judgment when sufficient information is not available. And there is one concept in Japanese philosophy which is known as wabi-sabi. It tells you that we have to find joy in imperfection. So all the narratives what we see are imperfect, may not be containing all the information, but we have to draw the inference out of it and try to code it, though till the time when all the information is available. I think I'll stop here and hand over to Dr. Rakesh, please. If there are some doubts, we can clarify.
So there's one question, Dr. Sitansu, from one.
Yes, please.
Is that it is mentioned that the patient hit his head. So why can't we take this as site specific? That is the question.
So head injury is let me see the question. Head injury is why the person fell and what is the mechanism. That is the mechanism of injury, but that's why we should not go by that. It is because of accidental fall or road traffic injury or fall from a two-wheeler. So there was a lot of confusion for this particular case happened. So ultimately then we realized that probably accidental fall best suits to the cause of underlying cause of death. So that's why I thought that should be discussed with the group. Any other opinion will be always welcome.
Yes, sir. Another, I mean, in this again, we are clear that, and that we have put in our training manuals and emphasize that site of injury is not important. The mode of injury is to be coded underlying cause of death. In this case, head injury may be the ultimate cause of death, but since it was because of fall, so fall has to be coded underlying cause of death. This whole focus on underlying causes of death is where we can intervene so that that event can be kind of prevented. And that's why we have said that SNT codes, which is basically focused on what is the site of injury, etc., is not to be coded. And there have to be corresponding codes in the other chapters, which tells us the mode of injury that has to be coded. So that, I think, clarity we're trying to bring in through all our webinars. That is one recurring theme, that SNT code should not be there. Site of injury should not be coded. We should be kind of focusing on what is the what is the mode of injury to assign underlying cause. So I can't see another kind of question. So Dr. Farhad, you can address.
Brief, I will go for my second. So this is the so this is the narrative which was already in English. So just the key points: 77 years old male, old age related illness and weakness. There was a history of hypertension mentioned in the narrative itself since 6 months. and was not taking any treatment. On the day of death, the one who is narrating informed that the BP increased, but we do not know how he came to know that BP increased. There was sudden unconsciousness and died on the same day. And there is no history of any heart disease mentioned in the additional part, no history of any chest pain mentioned in the narrative itself, no history of any paralysis or deviation of the face mentioned in the narrative. Usually in narrative, we might find they mentioned that there was a deviation of the face, paralysis, or there was intense chest pain, sweating. No, nothing of that mentioned in the narrative. In additional information, we do not get all those, but in the narrative, nothing was mentioned. But there was hypertension, sudden unconscious. So can I go for the audience poll, please? Jaldi se.
Sure, sir. Sure, sir. Sure.
So based on the narrative, what could be the underlying cause of death with the coding? A is acute MI, I-21. B is stroke, not specified hemorrhagic or infarction, I-64. C is essential primary hypertension, I-10. And D is ill-defined and unknown cause of mortality, UN99. So I think this looks to be a straightforward case. Let us see. It should not take much time. I think enough time is there for this case. We can close down.
Okay, sure, sir. I'm sharing the results.
Did you
So
express
46% as stroke and 40% is as essential hypertension, and MI is 8%, and some even are 99. Okay. So in brief, let us discuss. Firstly, we have a history of hypertension without medication, BP increased. This is all narration only, but a history of hypertension both in narration and also in the information part. No history of any heart disease. That information we are getting from the additional information, or there was no mention of any chest pain that we might have expected in the narrative. So all the above points goes in favor of stroke, that is I-64. And another history of hypertension without medication, sudden unconscious, no history of any paralysis or deviation of phase. So all those above points goes in favor of MI. So let me, in very brief, let me tell you, we always have some difficulty in whether it is a stroke or it is I-21, acute myocardial infarction. When that paralysis, hemiplegia, deviation of the phase, on the other side, chest pain, sweating, ghabrahat, in Hindi they call it ghabrahat, something like that is missing. So there is no headache, no sudden fall down, and paralysis, no deviation of the phase. And on the other side also, there is no chest pain, no sweating, no uneasiness. So in such case, it becomes a bit difficult. Now, sudden unconscious, if there is a massive stroke, massive hemorrhage, or there is a occlusion of the major artery. So if there is a massive stroke, we may have unconscious and sudden death also. So how do you elicit paralysis? The narrator might not have noticed that there is paralysis because already the person was unconscious. So mostly sudden death happens in case of myocardial infarction than stroke. In stroke, ज़्यादातर हम देखते हैं, what we see is that the stroke patient may survive for long, then bedridden, then ultimately die, whatever it may be. But in case of acute MI, I-21, we see more of sudden death as compared to stroke. But it is not that in stroke there is not sudden death. There might be, if there is massive hemorrhage or massive occlusion leading to infarction, and there may be unconsciousness and sudden death. So here I have gone with the I-64 because history of hypertension is there. and sudden unconsciousness is there. So I have gone with I-64 rather than I-21 with the absence of any history of chest pain, because silent MI is rather uncommon unless there is a diabetes and all, rather than stroke. So I have gone with I-64 and have chosen it over MI. And as we know, we should not quote I-10 when there is nothing. Then we can quote I-10, as we have already discussed. I mean essential hypertension. Otherwise, we should not quote, and we should always try to avoid R coding. That is the unspecified R coding. R10, R99, R96. We should try to avoid. I do not know why such a big percentage of our coders have given that R coding when we have a clear-cut history of unconsciousness and history of hypertension. Thank you.
Thank you, sir. And we'll wait for some queries if some queries come.
You can take it at the end in case, Rakesh, you
Yeah.
can continue quickly. Yeah.
Yeah, so I think we are done here. So one message that I want to convey is that obviously when we do a overall autopsy, we have got a narrative. Narrative may be very good based on what the informant or what the close caregiver of the disease has conveyed to the interviewer, or narrative may be very vague. So it's not very, many a times it is not very easy to quote, and two coders might not agree with that, and that's why it's many a time. I mean, somebody asked, all that is written is just attack. So how do you interpret attack? I mean, attack can be anything. So all that we can kind of aspire or we can try is based on given narrative, how best, and obviously our own clinical judgment. So if say stroke is, so how is stroke present, or how is a myocardial infarction present, based on those clinical judgment, and obviously, and that's why doctors are being asked to code. Otherwise, and that's why physician coding many times is considered better than the. So based on our clinical judgment, we gave a code. That may not be precise, and that's why we say that at individual level, our codes may not be correct. But what verbal autopsy shows that at the population level, we are closer to the cause specific mortality fraction, and that's why we do this. So message is, please adhere to those kind of methods, those conventions, and obviously it's not always necessary that, and that's why we are having these discussions, these case discussions, what we should do. Obviously, it is challenging to code a verbal autopsy because you're not seeing a patient. Even when you are seeing a patient, you many times there is a kind of disagreement on diagnosis based on a narrative taken from someone who is being close. Obviously, it is challenging. So we'll keep on having these discussions at a regular interval, and I think that's it from my side. So you want to say something?
We have one more case, no, Rakesh?
No, no, sir. That's it, sir.
That's it. We're just
I had only one.
Yeah.
Okay. I think wonderful discussion we have had. I think key issues all came up. Most important is that there is no gold standard. These are judgments, and so people who adjudicate are not people who know everything. They do what is best available within this thing, and there could be difference of opinion even among adjudicators. So that's something that people have to understand. Ion and Rakesh, we keep discussing different problems that we face between each other, and we have sort of developed our own understanding of the issue. But these discussions, I'm sure, will help others also get those kind of an understanding and improve our. In the last, I think we presented, we are not happy with our the number of cases which are going to adjudication, and the R codes are too high in what we think in our about 15-20% are going to R code. So this effort is mainly to reduce those unclassified deaths and get a better agreement at the first level itself. It also saves time. Then it does not have to go to the third coder or to the adjudication. So we hope that with these kind of measures and with such enthusiastic participation of the coders, we will soon reach and we will start doing coding much faster and much better. So that's the whole purpose of doing this. I'm glad to see active participation of the other adjudicators also. And I think in future, I think there's a good idea that we have both the idea of the webinar as well as the idea of using these case studies with multiple adjudicators is an excellent way to go forward. I thank all the adjudicators and people who spoke today. And I hand it back to Dr. Bari, who is the moderator of the.
No, she is not there, sir. I think she had a meeting and she left. So,
okay, so I became de facto moderator.
Yeah, that's what I asked.
I had usurped that role without asking her permission, but it is. Anyway, thank you everybody for joining us and staying till 5:50. So anything else anybody wants to say?
I want to say a good thank you to Dr. Sitanshu, Dr. Farhad, and Dr. Biswata for bringing out such a wonderful case study. And of course, our Dr. Kadal, Dr. Ayan, for organizing this.
My pleasure.
Thank you, sir. Thank you. All.
Thank you, everybody. Right. Bye-bye.
On behalf of Planet, I would like to thank all of you. Thank you so much. I'm ending the meeting.
Thanks, sir.